What's up, everybody? This is the third time I've tried this. I just spoke for about, I don't know, 15 minutes before I realized that I wasn't screen sharing. So I'm going to try to have just as much enthusiasm on this one as I did on the last one. Okay, so my name's Dr. Peter Noël. I'm a board certified veterinary radiologist. I'm thankful that you're watching this. My hope is to provide you with some knowledge and some opportunity to refine your diagnostic imaging interpretation skills so that you can feel more confident when you see patients in your own clinic. Now, oftentimes I hear complaints about patients coming in for acute vomiting and clinicians having the difficult time of trying to decide, is the animal obstructed? Does the patient have a small intestinal mechanical obstruction or not? And so, in that vein, we're going to look through numerous cases of patients of abdominal radiographs in dogs and cats, and your job is to try to decide, is this patient obstructed or not? Now, these patients, I've taken these studies from a research project I did a while ago, wherein I had to acquire 100 cases of dogs and cats, dog or cat, that had acute vomiting and had a known outcome of either obstructed or non-obstructed small intestinal mechanical obstruction. And so we confirmed their outcome based on ultrasound and or exploratory laparotomy. So all these cases, we know what happened with the patient, and so we can use these to sort of test ourselves and refine our skills. So one of the things that I'll show you is a Likert scale. It's a 5-point scale that we use during the study that I would encourage you to practice and use in your clinic, because in my mind, if I can lump one of the studies onto one of the grades of the scale, it can then help me decide, well, what's the next best step? In other words, do I cut the dog? Do I do an abdominal ultrasound? Do I do nothing? Do I provide supportive care and fasting, and maybe 12 hours later do repeat abdominal radiographs? And so sometimes the scale can be helpful. Now, you won't necessarily need the scale for this presentation because it's either a yes or no, but I think the scale could be helpful. So here's the scale. Okay, so modified 5-point Likert, grade 0 to 4. The zeros and the fours tend to be, easier, definitely obstructed, and definitely not obstructed. The ones that can be a little bit more difficult are these ones sort of in the middle, probably obstructed, probably not obstructed, and really just sort of a toss of a coin. So if the dog is definitely obstructed based on your assessment, you're free to cut it. If it's probably obstructed, you're also free to cut it. In those cases, I tend to, because of how expensive and invasive surgery is, I tend to say, look, the wording I use is get an ultrasound now. You got to get an ultrasound. If you can't get an ultrasound, you need to do something, some sort of follow-up imaging now. That could be a barium study. Maybe you wonder if this thing's in the colon or not, so you do a pneumocolonogram. You could do a compression abdominal study if you're worried about something hiding and you can't really see it. So probably obstructed. We need something now. Don't let the animal go home. Indeterminate, that could be something like, follow-up radiographs after 12 hours of supportive care and fasting. That's a really good thing for the indeterminate, where maybe you want to see if the stomach has reduced in size, maybe the small intestine has reduced in size, and so on. Probably not obstructed would be a case where you may not necessarily need to do any imaging, follow-up imaging, unless the animal's not better within about 24 hours. So I usually say, look, if this animal hasn't improved within 24 hours after starting supportive care, you should probably do something like an abdominal ultrasound, or at a minimum, repeat the abdominal radiographs in order to compare. And then definitely not obstructed is also kind of similar, where benign neglect. Look, if this animal, we're really expecting that the patient does not have an obstruction, does not need surgery, and probably should not be coming back. If it does come back, then I think an ultrasound is warranted, and not follow-up radiographs, because there's probably something else, kidney disease or what have you, that's causing the patient's problems. Okay, so here's the Likert scale. First case, we've got 3 abdominal radiographs, a left lateral, a right lateral, and a VD view. Okay, so first thing I'm going to do is stop talking for about 30 seconds, and I'll flip through the study, form your opinion, and then I will tell you what I think. Okay, So this is like GI obstruction boot camp. Okay. So, um, first thing that I'm going to do is walk you through how I interpret an abdominal radiograph. I do it in the same way every time so that I can minimize errors. Okay. So, first thing I do is I look at the caudal thorax because you will miss pneumonia if you're not looking for it. You get too focused on the gut. So, caudal thorax is normal. The liver is normal. Yes, the gastric axis is tipped forward a little bit, but subjectively, I think that there's adequate liver here. Okay. Splenic tail, splenic tail, splenic head. Spleen's normal. Left kidney, caudal pole of the right kidney, probably a portion of the cranial pole of the right kidney. Right kidney, the cranial pole is effaced, border effacement with the caudate process of the caudate liver lobe. Both are soft tissue / fluid opaque, so you're not going to see the difference. But you got left kidney here, the caudal pole of the right kidney there. Then I look and I go urinary bladder. You have any calculi? It's pretty empty. Next thing I do, so I look at the mesentery. I go, it looks like serosal detail is good. I can see margins. Okay, so I sort of look at the extraintestinal stuff. I zoom out and I go, what's the vertebral column look like? The extra abdominal structures. This is motion artifact, which is why it's blurry. Body wall, body wall. Okay, now we get into the guts. Okay, first thing that I look at in the GI tract is the stomach. I want to make sure it's not overly distended. This stomach is not overly distended. I would describe it as mildly gas filled. Recent report said you don't need more than 2 views of the abdomen, but I disagree. I like 3 views. It's helpful. It's not that much more of a headache. It certainly shouldn't cost the client any more money. And plus, with the stomach in particular, you can compare and contrast laterality to determine if there's any outflow obstruction. And so this is a left lateral view. On a left lateral view, the patient's left side is on the table. And so all of the contents should theoretically move to the fundus and body region and then open up the pylorus. The right lateral view, in this particular case, just doesn't have gas. And so it kind of looks soft tissue opaque like that. Next thing you want to find out, where's the colon? Okay. Because once you know the stomach, then you find the colon. Everything else is small intestine. And so here's colon, 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 colon. There's transverse colon coming at us, and then there's ascending colon, and this is cecum. Okay, cecum. Colon, 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 cecum. So one of the colon likes to live in this particular area. Okay, so if you see any big loops in this area, you want to keep in mind that it's possibly the colon and not necessarily small intestine. One of the caveats to that is if the patient is rotated, which you can use sort of the ribs and how offset they are relative to one another. If the patient is rotated pretty significantly, it can dump the colon down here, and then you could misinterpret that as a pathologically distended segment of small intestine. Okay, so next thing is small intestine. I describe the size, the course, and the content of the small intestine. The size, too big, normal, and then is everybody the same? So ideally, everybody needs to be sort of the same size or fairly similar in size. Okay, small intestine, small intestine, small intestine, small intestine, small intestine. Course, corrugation. Okay, corrugation looks like a bacon strip on an abdominal sonogram, and it's just an angry bowel, angry set of small intestine. It's corrugated, and it kind of has this serosal outside margin is fairly smooth, but the mucosal surface, the inner side, is just sort of undulates. Versus plication, which is the term that implies you think the animal has a linear foreign body obstruction, and that's where the whole all the layers of the small intestine are sort of they undulate, and so you've got a linear foreign body. So size, course, content. Is it empty? Does it look like there's fluid? Does it look like there's a radiolucent or a radio-opaque foreign body or some sort of combination? Okay, so case number 1 is not obstructed. This dog is not obstructed. This dog is definitely not obstructed. I'd give this a grade 0. This one probably has some gastroenterocolitis because the colon has like partially formed feces, maybe some fluid in the cecum, small intestine's empty, stomach's empty. So, all right, case 1 in the books. Here we go. One of the things that I'll mention too, these cases that I pulled from my residency, because I pulled them from the residency, they are stored in JPEG format, which you should not be interpreting JPEG images, but these particular JPEGs have been optimized for viewing. And as such, we will be able to draw some information from from them and use them for our purposes. Okay, so here we go. Case number 2. Okay, so case number 2, we have a right lateral and a VD view. Now, remember, all cases, all patients are presenting with an acute onset of vomiting, and they have known outcomes. Okay, so I'm going to do 30 seconds. When you review this later, you can pause it and so on, because normally I would give you a little bit more time for review. So this is a cat. We know it's a cat because it's got these long lumbar vertebrae. Okay, so this is an obese cat, probably because he's sitting inside, just kind of looking out the window. Okay, so same thing: caudal thorax, liver, kidney, left kidney, right kidney, urinary bladder. The spleen is kind of hiding here. This, for the uninclined or uninformed rather, is the left limb of the pancreas. You can see it sometimes in a very obese cat. Left kidney, right kidney. Okay, mesentery. I can see borders very well. Retroperitoneal serosal detail is great. So, okay, next thing, stomach. In a cat, okay, this stomach is a little bit too big. Now, I don't want you to look at this stomach and go, it's just full of gas. Okay, this is gas, but you see how that's fairly radiolucent, very dark, fairly dark, kind of looks like the dark lung. This is a little bit more gray. And my guess is that there's gas here sitting on top of fluid. And so I would describe this as a mildly to moderately fluid and gas filled stomach. Okay. When you see a stomach that looks like this in a cat, you should start really, really scrutinizing the study. Cats, as I was taught, they don't drink a bunch of water and say, hey, let's take a radiograph. So this is an indication that you need to start scrutinizing the study. Okay, same thing in a dog. This is the colon, and there's the ascending and transverse are sort of superimposed in this area. Now, some of the things that you can glean from the colon is that there are formed feces, which would support the history that this is an acute process. Okay, so this is colon, which means everything else is small intestine. Okay, small intestine. Okay, so this small intestine is pretty empty, mildly gas filled, looks pretty good, size, course, and content. When you flip the cat over, you go, okay, here's colon, and then I'm not going to pretend like years and thousands of radiograph interpretations are going to make me see the ascending colon and the ileocollic junction. You don't often see the ileocollic junction in cats like you do in dogs. Okay, but this thing is not that long. It's got to come around and kind of sit here. Okay, so with that in mind, what is this? So this loop right here, way against the border, way over to the right. Okay, it's too big. And one of the things that we could do is you'll notice right through here, this loop has what appears to be some poorly defined soft tissue structure in it. Okay. So now all of a sudden we've got what looks to be a segmental enteropathy. So this loop appears to be the only loop affected. There does to be some vague material in here, and the stomach is too distended. So this patient has a small intestinal mechanical obstruction, and you could cut this patient. I would consider this somewhat of a challenging case. And it also highlights the fact that you need that orthogonal view. I cannot see the foreign body over here. It's probably hiding in this area. Okay. So, case 2. If you were unsure, if you didn't see that and you go, well, what could I have done? I think in this particular case, if you didn't see this, then you're probably going to say it's definitely not obstructed. But if you see a stomach that's this distended with some fluid in the cat, you could always offer follow-up imaging, whether that's come back in 12 hours or that's an abdominal sonogram now, because it's just not normal. Usually the cat stomachs are empty. Okay, that was case 2. Okay, case 3 is 3 radiographs. 1, 2, 3. 1, 2, 3. Feel like we're at the optometrist. How about now? How about now? Okay, 3. Go for it. 30 seconds. Okay. Again, you can feel free to rewind and stop. This is an obese dog, shorter lumbar vertebrae. Caudal thorax looks good. Okay. I take that back. My apologies. There's right-sided chronic rib fractures, maybe a left-sided chronic rib fracture. So 13, 12, 11. There's probably some mineral callus there. 11. I don't know about that because there's superimposed costochondral junction, but that those look fractured and chronic because I see mineral opaque callus. This impression of a bronchial pattern is likely from the technique and the beam divergence, so I would chill out on that. Liver is fine. Gastric access is fairly parallel. However, you've got sort of this rounded bulge and then this cute little thing right here that's coming from the liver. So it's possible this is a pedunculated gall bag or gallbladder that is either physiologically distended. Perhaps you've got a gallbladder mucus seal, but maybe that's the gallbladder. And then what's this? Maybe this is a mass, and then you could Chang lesion, cyst, hematoma, abscess, neoplasm, granuloma, and so this could be something like that. Spleen looks good. Spleen looks good. Here's the left kidney. Here's the right kidney. Okay, so we're working through. Here's the urinary bladder. Cystic calculi. Okay, stomach. Mildly gas-filled. Gas. See how it's black? This is less black, but I still think there's not a ton of fluid in here. Okay, so the stomach is mostly empty, aside from gas. It's properly positioned. Next thing is colon. Okay, so animal's a little rotated, not a ton. But this colon dips down. So other caveats, if there's a large amount of intra-abdominal fat, sometimes this will dip down and just mess with you. But this is colon. Luckily, in this case, there's partially formed feces, and you can follow it. It kind of comes up here, and I lose it. But I know that cecum has got to be right there. And so this is probably, any big loop in here is probably going to be colon. On the VD view, it slides way out here, goes over here. I kind of lose it. Maybe it's this structure. And I don't really see the cecum. So if at worst this gas-filled loop is the colon, this is probably the duodenum, then that means everyone else is small intestine. And you go, okay, size, pretty empty or mildly gas-filled. Course, gentle turns. I mean, that's a nice gentle bend. And you'll see some are over here, some are over here. So you got right abdomen, left abdomen, cranial abdomen, caudal abdomen. If these were plicated, they would be stuck up here. They wouldn't sort of accommodate, they wouldn't sort of extend out to all areas of the abdomen. So size, course, content, mostly empty. So this is a negative obstruction. Piece of cake, right? Negative. Okay. Same thing. We've got a right lateral view and a and a VD view. Acute vomiting. Okay. Caudal thorax. Well, there's a lot of fat. Hair's wet hair. Caudal thorax looks good. Liver looks good. Spleen looks good. That's probably the tip of the pancreas. Looks good. Kidneys, less thrilled. So it looks like there's one kidney right here, and then it looks like it's superimposed over this larger kidney. So there does appear to be renal asymmetry, and there is this sort of pinpoint mineral focus there, which could correspond to that pinpoint mineral focus there. But I'll be honest with you, I'm having a hard time deciding if the renal asymmetry, it may be that there's the larger right-sided kidney here and a chronic left kidney. So you may have chronic left-sided renal disease and maybe some compensatory right-sided hypertrophy. There's also cystic calculi. Maybe there's some more sinister pathology involving the larger of the two kidneys, such as an obstructive uropathy or nephritis. But the urinary bladder is very distended. When you see a distended urinary bladder like this with mineral calculi, you go, all right, well, let's make sure there's not a urethral obstruction. And so you kind of look through here, and I don't know. Probably not. So I don't really see anything that makes me definitive. But you'll see how sort of poorly mineral opaque those are. So you got to make sure that there's not an obstruction. Use the clinical sign, stranguria, things like that. Peripherally introduced catheter, PICC line, left caudal limb. So next is the gut. stomach. Okay, compared to that one that we just did a few minutes ago, this is a completely gas distended and mildly gas distended stomach. That's good. Here's a colon. Okay, this colon has a small to moderate amount of formed feces. Okay, and it comes over here and it goes over here and it kind of comes around and I lose it, but it's probably doing something like that. Okay, which means that this is all small intestine and this is all small intestine and all this is small intestine. So then you go size. I would describe these as mildly, uniformly gas distended. So everybody kind of looks the same and they're all mildly gas filled. The course, gentle turns. Okay, so there's some in this part of the abdomen, some up here, some up there, some up there. Yes, when the urinary bladder is that distended, it's not going to let these loops go back here. So it does look more kind of, as you may say, bunchy or whatever term you want to use. But that's just because you've got this space occupying structure here. So gentle turns, normal in course, and the content, they're gas distended. You should really pause before cutting any animal that's filled mostly with GI gas. And the reason is because usually within 24 hours after an obstructive process, the gut starts to pool fluid. And so you will get a mixture of gas and fluid filled structures. I guess if you caught the obstruction incredibly early, which often doesn't happen in our veterinary patients, especially cats, because they go hide under the bed to die, and then they come out a couple of days later. Usually there's some sort of variability in the content. In other words, some loops have gas and some have fluid. So if you see a gut like this, where it's almost all gas and everybody's the same size, don't cut it. This is negative for a GI obstruction. Okay, here we go. So we got 1, 2, 3, 4. Obese male dog, probably older. Hips are kind of trashed. It's called a lumbar intervertebral disc space is maybe kind of narrowed, though. That is an area that I've found when the spine or the vertebral column sags on a lateral view, you can get this impression of narrowing without it not really being there. The caudal thorax, okay, looks pretty good. I don't see any evidence of pneumonia, though this left lateral view, you don't get a ton of it. The liver, yes, the gastric axis is parallel, but it's a little rounded. So maybe it's a little bit swollen. Spleen, I think, is okay. Splenic head is right here. So there's no evidence of splenomegaly. Here's a left kidney. Here's a portion of the right kidney. Okay. Oh boy, where's that urinary bladder? Here we go. Urinary bladder, small, fluid filled, or fluid opaque, rather. Left kidney. Stomach. Here's the stomach. Okay, right here. Stomach is only mildly gas filled. However, on a left lateral view, you've got this amorphous mineral opacity that's in the pylorus. That's not normal. Okay. Then there's such chaos involving the remainder of the GI tract that it's hard to determine what's colon. So yes, I think this is colon because it has to go through that pelvic inlet, but I kind of lose it. So you can hallucinate that it's probably in here. But even if it is one of these big loops, there's way too many loops that are too big, right? This is too big and fairly ventral, though he's rotated. This one's too big. This one's too big. This one's too big. These are too big. This one's maybe more normal. This one's maybe more normal. That one's only mildly distended. There's this loop back here. So now you got a problem. You got amorphous soft soft tissue / mineral in the pyloric outflow on a left lateral view. This is a pathologically distended duodenum. It's okay that you don't know that, but you've got distended loop with more foreign material, distended, but some empty ones. So you've got a segmental enteropathy with pyloric foreign material. So this is a mechanical obstruction. This is a surgical abdomen. You don't need to ultrasound this patient. I bet you all got that one right. All right, 3 views. Here we go. Start the clock. Acute vomiting, known outcome. What do you think? Let's do it. All right, here we go. This is a male dog. Well fed, caudal thorax looking good. Liver looking skimpy on the VD view. Gastric access is parallel. It's there's not a ton of it, so you wouldn't be wrong to check some hepatobiliary enzymes if those are abnormal, protein C analysis, bile acids, but stomach's a little bit distended with fluid and gas. That sometimes can make the liver look smaller. Plus, it's parallel to the ribs, which is sort of our criteria for normal. So I bet it's normal. Spleen, normal. Left kidney, normal. Right kidney, normal. Urinary bladder, fluid opaque. Urinary bladder, kidney, splenic tail, left kidney, splenic head, skimp liver, hip joints, caudal thorax, mesentery. I can see margins. So I can see good serosal detail. So left lateral view. So this is what happens. The stomach is right here. It comes around here. Pylorus loops around here. Here's pylorus. And then this is duodenum. And then it takes off down here. And then I kind of lose it. Okay. So this is mostly a gas-filled pylorus on the left lateral view. I think the stomach has a little bit of fluid and a little bit of gas. So it's not overly distended. Then you go colon. Boy, we don't get a lot of help on this one. So it is right here. But then I kind of lose it. It may be this one because dog's pretty rotated, but that is still in our area of play for the colon, and I don't really see it. This is the iliopsoas right here. Okay, this discrete margin right here. That's the filet mignon. That's the muscle belly that lives up there. So don't think that border right there is the colon. Colon's probably somewhere in here, and that's definitely the cecal area and the ascending colon. Okay, so you got stomach right here, only mildly gas filled. You got a pretty empty colon, and then you're looking at these loops, and you're like, well, these loops right here, they have to be small intestine, and they are small intestine, small intestine, small intestine, small intestine, small intestine, small intestine. So the size. So these are mildly gas distended, and I think that they are a little bit bigger than some of these other ones. Content. Mostly gas filled. There looks like there may be some soft tissue debris, whether that's incompletely digested food or it doesn't look like overt foreign material. Okay, so you've got some mildly gas distended segments of small intestine in the caudal abdomen. It's a bit segmental. Though, if you ask yourself, are these like moderately or severely distended? I would say no. And of course, that takes time and it's a subjective thing, but we compare it to the previous study. These are only mildly distended and they're mostly full of gas. And so, yes, they're doing this like stacking thing. But I think in this particular case, this dog does not have a GI obstruction. And so if you're struggling with this case and you're like, well, I don't know, man, this worried me. I think what you should try to get yourself to the point that you should get yourself to is to say, based on this and what I'm learning is that maybe this is not a definitive obstruction. So do not cut this dog. You would not be wrong to say these loops scare me because they stack a little bit. They're a little bit bigger than everybody else. And there is this sort of amorphous soft tissue in some of them. And so I'm worried. And so I'm going to say that it's probably obstructed. And in that case, you should offer some sort of follow-up imaging, ideally in an abdominal sonogram. So this is not obstructed. I think this is a more difficult case. But hopefully what you can learn as we go through a few more cases is that these grade 4s, which are definitely obstructed, I think you will start to appreciate those as definitely obstructed. And then everybody else, you should chill out. And so this is one where you should maybe chill out. Okay, so 2 views, right lateral, VD view. You know the drill. Let's boogie. All right, here we go. Okay, this is a male dog, well-fleshed. He's probably older. His back hurts, right? These are collapsed. There's mineral in the frame or at least superimposed with the frame, and these are narrowed, and they're pathologically narrowed. So bad back. Hips, it's a caudolateral curvilinear osteophyte. Circumferential femoral head osteophyte called a CFHO. It's a misnomer because it's an enthesophyte, but that's an indication that there's some mobility. Caudal thorax looks pretty good. He's rotated. He's very rotated, but I don't see anything on the caudal thorax over there. Liver's rounded caudal ventral border, so it's a little bit big. Kidneys are superimposed over here. There's the left kidney. just sort of as a brief tangent, would we be surprised if it was a diabetic? I mean, it's probably an older dog, and yes, you get attrition of the nephrons, and the kidneys get smaller as you get older, but the liver is kind of pudgy. And one of the differentials. So, are these kidneys maybe relatively large? I mean, they're objectively okay, but they're kind of chunky for what I presume to be an older dog. And then you go, let's make sure he doesn't have diabetes. That'll cause a little bit of mild bilateral renomegaly. Okay, but urinary bladder is pretty empty. I don't see it. It's probably the ventral border here, and I think this is it. So fluid opaque. Okay, let's talk stomach. Okay, this is stomach into this area right here. It's a right lateral view. So when you try to see a ball foreign body or a tumor, that's all your eyes are looking at, a pylorus that's got fluid in it or is collapsed. Okay, so that's the pylorus. So this is the angle of the stomach. Okay, and then this is the fundus of the stomach right here. And then the body is probably coming over here. So there's something in the stomach. There's amorphous soft tissue in the stomach. It's probably kind of up here. And so the dog is vomiting. So when you see amorphous soft tissue in the stomach, you should probably pause. That's not normal. The colon, it's kind of hard. This is probably the colon over here. Colon's coming through here. This is probably all colon in here. Okay. All colon in here, all colon in here. Now, what I'm hoping that you're doing is that you're looking at some of these small intestine and you're like, something just doesn't look right. If you think back to some of those other cases that we just did, the intestine should be doing these gentle, obvious, delicate turns. And these, it's hard to see delicate. There's just like a glob of something here. It's opaque. It's just sort of more opaque here. It's just like more opaque here. They're just not making the gentle turns. This actually looks like a cecum, but this is way too far caudal. Cecum is L25, right of midline. So the cecum is here. So that looks like a cecum. Maybe that looks like a bit of a cecum. And this looks like a, crescent shaped cecum. So this is a linear foreign body obstruction in a dog. So linear foreign bodies in cats, I think, are much more amenable to seeing the plication. They're much easier to diagnose, but the small animal, the small intestinal obstruction secondary to a linear foreign body in dogs, I think, is a challenging test. So this is positive for an obstruction. This is a foreign body, a linear foreign body, likely in the stomach, perhaps anchored in the pylorus, but this is a surgical abdomen. 4 views. 1, 2, 3, 4. All right, time. So we got a radiation safety infraction, ungloved human digit right there. Not a good idea. Distal aspect of the os penis has a non-displaced separate center of ossification. Sometimes you'll see those a little bit further away from the distal aspect of the os penis, but that's not a problem. Caudal thorax is fine. You get the impression that these caudal physes of the end plates are like just closing. So it's as a young creature. Liver looks good. There's probably some splenic tail that's coming up here, and it's probably contributing. First of all, there's a fluid-filled segment of the GI tract overlying here, but there's a splenic tail that's coming up here, and then there's a ventral liver margin, and so it looks just a little bit more opaque. But this is the liver. Okay, here's the stomach hiding back here with what looks to be that stomach. It's mostly empty or has a little bit of fluid. Okay, but it's kind of up here. It's not hugely distended. There's probably the pylorus, and then here's probably the duodenum. Okay. Colon, it's here. And then if you're like me, you go, well, does it like fold back on itself and do this? And that this is colon. And so if you're worried, you could do a couple of things. You could flip the dog on its back and you could say, wow, if that's all colon, so this is too big. You go, that's too big if it's small intestine. So let's just say that that's colon. It shouldn't be over there, but if it's colon, that's a weird angle for colon to do that. And then you go, okay, wait, so that's colon, that's colon, that's colon, that's colon, this is colon, this is colon, colon. There's too many colons. So then you go, some of this has to be small intestine. And so then you go, this is pretty far ventral, and this is very far ventral, and colon, 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 colon. There's too many colons, so some of these have to be small intestine. And then this is turning down like that, so that's probably not the colon, because you will sometimes have a colon that comes out here, and on a lateral view, it kind of like dips and loops and folds on itself, and it'll kind of trick you. But this, I have a feeling, is small intestine. And so then you go, well, these are definitely small intestine and small intestine and small intestine, maybe, though that's in the area of the colon. Small intestine, small intestine. So that's small intestine, this loop right here. So you've got a segmental enteropathy, and so you've got an obstructed dog. Compared to the other study, which was just plicated, you can still see these margins. I mean, you can see the loops. You see the gentle loops. You see the gentle loops. So for me, the course is fine. It's not plicated. It's just gentle. The content, there's a mixture of fluid and gas. Remember, we said after about 24 hours, it pools the fluid. So you got a fluid and gas, segmental. Some of these are too big, and they're really big. And some of them are small. So this is test positive for small intestinal mechanical obstruction. Let's say you're alone in the clinic, you're freaking out, you can't tell. This would be a great case to go pneumoclonogram. Okay, you just pump a bunch of room air, dump that in there, and then you'll go, oh boy, that's not colon at all right there. He's obstructed, and then you cut him. Piece of cake. Remember, name of the game is seeing cases. We got to see cases. Okay, so 2 views, VD view, right lateral view, go for it. Okay, this is a cat, right? Fat cat, long lumbar vertebrae. It's a fat gatto. A little bit of mineral opaque, call these meniscal ossicles. Boy, I've seen those in really young patients, and they're oftentimes, well, I shouldn't say they're oftentimes not a problem. These are very common, and they may not be clinically relevant. Caudal thorax, we see anything crazy? No, a little poof of the diaphragm, and you go, well, what is that? That's weird. But then you go, well, the diaphragm is more normal on this side. So some of that could be beam divergence. If this were hemiparalysis of the diaphragm or a true diaphragmatic hernia or other abnormality, I would expect it to persist. Though I suppose you can have some hernias that are dynamic, but I'm not that worried about it. This is the liver, and it's too big. And usually with fat cats, you get a big falciform ligament, and it almost makes maybe you've seen these, but it almost makes the liver look small in a cat. So for the cat to be this well fleshed and the liver to kind of come down here, it's too big. Kidney, 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 kidney. Those are nice looking kidneys. So if he's older, you go big liver, big kidneys. We got a diabetic, maybe. Urinary bladder, small, fluid opaque. Okay, stomach. Remember we talked in the first case of the day. You don't want to really see a ton of stuff in the stomach. So you go, okay, stomach, fluid, gas. Here's the cat's stomach, comes over here. I lose it, but it kind of comes over here. So stomach, mostly gas filled, right? Mostly gas filled. You use this view to go, wow, this is really black. A lot of black, 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 black. A lot of radiolucency here. So a lot of gas. There's probably a little bit of fluid, maybe some foam, but it's a little too big. So then you go, all right, now I got to be real careful that I don't miss anything. So in this view, you go, this is colon, 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 colon. And my guess is the colon loops on itself, and this is all colon. And what you can do to kind of support that is use the lateral view. It comes up here, and this is probably that section of looping here, and then it kind of comes down, and it's got some fluid in it, and then it probably kind of comes back up towards the ileocolic junction. Okay, so this is a colon that's got some fluid and some gas. So then you go, okay, stomach, so this is all colon, 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 colon. So then everybody right here is small intestine. And then you go, what's the size? Well, a little bit of gas stippling, maybe, and this will take some practice. Some of these, if you filled this loop right here up with fluid, it could look empty. The only change is that it's bigger in diameter, and playing that game of is it empty versus mildly fluid filled can be quite challenging. And to make matters worse, it could also be thick walled and empty of gas and still kind of look thick. So these to me look like they're a little bit too big, and they're soft tissue / fluid opaque. So a lot of these loops could be thick walled, fluid filled, both, but they're all fairly similar in size. Okay. Some over here, some over here, some over here, some over here. A lot of gentle turns. That's a nice gentle bubble, gentle bubble. This thing goes out here, gentle, gentle, gentle. Okay, so size a little bit too big, but everybody's the same. Coarse, I don't see corrugation or plication. Content, a little bit of fluid, a little bit of gas. This is not obstructed. That other case, we saw some wonky loop way out in the right lateral abdomen. I don't see, I mean, this is like a little bit big with a little bit of gas, but it's stacked on this other loop right here. Nothing crazy like an obvious foreign body in that other one that you could only see on one view. So this is gastroenteral colitis. This cat is not obstructed. And, maybe he's got diabetes and he's got some pancreatitis or kidney disease or some other cause. Okay. Let's do this one. Okay. On the heels of the last one. This is DICOM. Let's see. I'm going to show you, it's 5 views, but I'll give you the abdomen. Okay. So here we go. Right lateral view. VD view. Left lateral view. Okay. Okay. Here we go. This is a cat. Long lumbar vertebra. That kind of looks like a physeal remnant, like it just closed. So maybe a young cat. Caudal thorax. Caudal thorax. Caudal thorax. There are 6 lumbar vertebrae. 1, 2, 3, 4, 5, 6. That last one looks transitional. Liver looks good. Kidney looks good. Urinary bladder looks good. This is the stomach. That does not look good. This is the stomach. This is the stomach. Okay. And using our little physics lesson about gas or gas cap on fluid, this is black. Radiolucent because it's mostly gas, and this is more gray, and you've got this sort of thing out here. So this grayness is gas cap on fluid. This is a very fluid filled stomach. So I would say the stomach is moderately fluid and gas distended. The colon contains a small amount of gas and incompletely formed feces. Okay, the small intestine. Let's talk about it. Size, course, content. This is almost cool looking, you could say. This is kind of this undulation right here. Undulation right here. Look down here. Undulation here and here. Here. They look stuck to each other. And my old mentor called these omental wedgies. So this is a small intestinal foreign body obstruction secondary to a linear foreign body in a cat. Okay, this is, you need to cut the cat. And you'll notice that this is at least, if you've seen a couple of these, much easier to diagnose than in a dog. Okay, here we go. 2 views. One is a left lateral view and a VD view. Okay, here we go. This is the male dog that's got he's well-fleshed male dog. Caudal thorax looks good. Liver's, pretty good. Pretty good. Spleen's kind of chunky. I would say that's like a little bit of mild splenomegaly. Left kidney, right kidney. Urinary bladder is small and fluid opaque. Okay. Serosal detail. You can see fat here. You can see fat there. You can see fat in the adjacent small intestinal wall. So you can see these borders very well. You can see these borders all very well. I mean, look at that. You can see that very crisp. So serosal detail is fine. Stomach right here. Here we go. Stomach is mostly gas filled. You can see the rugal folds and it sort of like collapsed. Some of the other ones that we've seen today are these like really big fluid filled bags. So this is a mostly collapsed small intestine, which is great. This is a left lateral view. And so you'd really like to see a lot of predominant gas in the pyloric outflow, which you see here. So you've got a mildly gas distended stomach with a gas filled pylorus on the left lateral view. Next step is what's colon. Okay. So here it comes. Luckily we've got gas already in it. So gas, kind of lose it, but figure it's there. Gas, transverse, ascending, and that's probably the cecum. Okay. Comes out here. I kind of lose it, but then it comes over here and it comes over there. Okay. So that means that this loop, this loop, this loop, and all of these loops down here are small intestine. The name of the game is really, when you're dealing with the small intestine, is try to figure out what's not colon. So if you need to do whatever it is you need to do to find the colon, then do it. If it's a pneumocolonogram, great. Sometimes you can take a wooden spoon or a spatula, and from the ventral side, you compress while you acquire the radiograph as a way to displace GI and help better determine what's colon, what's small intestine. Is there something hiding? Okay. So if this is all small intestine, you go size. Hopefully by now you go, these just don't look empty. They look like they've got stippled gas, and these ones look like they either have fluid or they're thick-walled or both. Okay. So these are not empty. And then you go, are they all the same size? And to my eyes, when you sort of take a step back, you go, these are maybe a little bit bigger, but they're not substantially bigger. Okay. So most of them are approximately the same size, which is mildly enlarged with stippled gas, fluid, thick wall, some sort of combination. Coarse. Do you see any plication? Remember in the dog, it was just like a glom of stuff, and it was hard to see the borders of the gut. And this, you've got small intestine in the caudal, the mid, the cranial abdomen. It's back here. They're hiding over here. They're hiding up there. So there's no real evidence that these are plicated. And then the size, the course, and the content. We already talked about that. Fluid, gas. So this is not obstructed, this dog. This is a, in my estimation, I mean, I know that the outcome is not obstructed, right? But this is a not obstructed dog. And we feel good about it because the stomach's empty, the colon's empty, the gut's all got stippled fluid and stippled gas and some fluid. So this is gastroenterocolitis until proven otherwise. And I wouldn't do any repeat imaging unless this patient didn't get better within 24 hours after starting supportive care. Okay. Well, I think that should do it. That has been 1 hour of, is it obstructed or is it not? I will talk with the powers that be about trying to roll out a similar video that talks about some of the common cardiac related cases, pulmonary cases, pneumonia, heart failure, some of those that can be kind of tricky, especially in cats. So, but hopefully this has been helpful. And if you have any questions, feel free to email me, and I hope you guys have a good rest of your day. Thanks.